Good evening, everybody. Thank you all so much for joining me tonight in a live webinar. I'm Daniel Southern, and what you need to know about me is that I run a clinic called Interventional Orthopedics CT, and we're the only Regenerative affiliate in the state of Connecticut. I'm going to share my screen, and we're going to get started. Okay. So what we're going to try to do tonight with this webinar in an expeditious manner is to introduce a new field of medicine, explain the basic tenets of it, what it does, what it hopes to do, and how possibly it's going to change the way we practice medicine. The title is Regenerative Orthopedic Medicine, Orthobiologics, and the Birth of Interventional Orthopedics. There's a lot of terms there. So we're going to start by unpacking them a bit for you. Regenerative orthopedics, what does that mean? Well, let's compare it to traditional orthopedics. In traditional orthopedics, surgeons use a lot of tools. They're cutting, drilling, sawing, hammering, scraping, grinding. They're placing screws, plates, rods, nails, anchors. The metaphor here is carpentry. As opposed to regenerative orthopedics, we only use needles, and we use very advanced imaging to place those needles. We're injecting a patient's own blood and cells in an effort to change the chemical environment of a damaged tissue to stimulate growth and repair. The metaphor here is gardening. In traditional orthopedics, we're removing, rearranging tissues. We're replacing native structures. In regenerative orthopedics, we're trying to repair, we're trying to regrow tissue. The bottom line is that we are trying to preserve native structures. And this is one of the themes of the talk tonight. The importance of preserving your native tissues cannot be overemphasized. We're going to start now with the traditional treatment algorithm in any orthopedic office in the country today for a musculoskeletal injury. It starts with an injury. Now, you may be a weekend warrior and you sprain your ankle playing soccer, or you're just a klutz, you step off a curb and you twist your ankle. It hurts a lot, it swells up, it gets red and hot, you put some ice on it, you take some Advil. Most people will be better in 3 to 5 days. But if you're not, you tend to call up your PCP and say it hurts. And they say, well, why don't we go to physical therapy? And they write you a script. Here again, most people will respond in a matter of 2 to 4 weeks and they're better. But if you're not, you go back to the PCP and he refers you to his friend, the orthopedic surgeon. You go to the orthopedics office and he says, oh, you're not getting better. Let's do an injection. So they inject you with steroid. Now, an initial injection of steroid can be quite miraculous. But what happens after a couple of weeks when the effect wears off and the pain comes back? You go back to the orthopedic and he says, well, now we need to get an MRI. Well, if you're standing in a surgeon's office and you're looking at an MRI, your chances of getting surgery have gone up about 90%. So they see something and they propose a surgery, and let's say you have a surgery. And that works or it doesn't work. And in a year or two, maybe, you come back, it's hurting again. What do we do now? He says, well, we got to clean up that arthritis there that you're developing. So another surgery is performed. Give it another 5 or 10 years, and you come back and looking for another surgery maybe. And he says, no, can't do that anymore. Now we got to replace that joint. So this is the traditional algorithm as practiced in musculoskeletal medicine today. Well, what's wrong with that? Well, what's wrong with the algorithm? Let's start with steroid injections. Steroids are toxic to tissues. They kill the very cells that keep your cartilage, your bones, your tendons, and your ligaments healthy. They reduce the joint cartilage volume, they weaken ligaments, they weaken bones, they suppress the immune system, they increase the risk of diabetes and infection. So the point is, whatever you're getting in the short run with steroids, you're going to pay in the long run. And that's another theme of this talk. The local anesthetics that we use to inject with steroids, bupivacaine and lidocaine, are probably even more toxic to the cells we're trying to support than steroids are. What's wrong with the algorithm? Meniscectomy, also known as we got to clean up that arthritis surgery. Meniscectomy is the removal of meniscus. The meniscus is a large chunk of cartilage that lives on either side of your knee, and it reduces the forces that pass through the knee. It's a very, very important part of your knee anatomy. The problem with meniscectomy, which is done for knee meniscal tears, is that it increases your risk for arthritis. Over the course of about 8 years, your risk of arthritis goes up at least 3 times. Why should that be? Well, it's not hard to imagine why. If you take out forces that, you take out the cushioning structures in the knee, the loading forces in the knee increase. And if the loading forces increase, degeneration in the knee is accelerated. What's wrong with the current algorithm? Shoulder, rotator cuff repair. The data here is really not good. Re-tear rates are 1 in 5 overall at 6 months after a procedure. That's 20% of rotator cuff repairs. The re-tear rate is directly correlated to tear size, so larger tears have a much higher rate of re-tear. About 6 in 10 of those will re-tear. And as we get older, 1 in 3 tears, just 30% of them, just won't heal at all at 1 year after surgery. Only 50% of professional athletes who have rotator cuff surgery return to the same level of play. What's wrong with the current algorithm? Knee ligament repair, traditional ACL repair. This is a flagship procedure done by orthopedics, and they're rightfully very proud of it. It gets professional athletes back on the field. It solves the instability that comes about when you tear an ACL. And that instability is front and back in the knee. The problem with it is that, first of all, traditional ACL repair is not a repair. They take out your native ligament and they place a ligament that they harvest from another part of your body or from a cadaver. And the problem with that is that the angle of the native ligament cannot be reproduced. Here's a cartoon of ACL repair. The native ligament is here in red. It's very, very shallow, the angle. When they repair an ACL, they have to drill in the back of your thigh bone, the femur, and drill in the front of your shin bone, the tibia, and they thread a replacement ligament through here at a much steeper angle. And we think that that steep angle is what causes rotational instability. So while you're solving the front and back instability, you've created a new instability, a rotational instability. And we believe that that instability is partially what accounts for the fact that when NBA athletes have this procedure, they play for less than 2 years following the repair. NFL athletes suffer sustained decreases in performance. And Dr. Coker from Harvard recently published in a New York Times article stated that the chance of arthritis within 10 years of ACL repair is greater than 50%. 2/3 of athletes who are teenagers will develop arthritis in that knee that has been repaired by the age of 30. And finally, what's wrong with the current algorithm? Joint replacement. After joint replacement, there's minimal functional improvement. Only 1 in 20, that's 5%, will achieve normal activity levels. And many patients following joint replacement complain of continued pain. And studies show a range of patients, but quite possibly 50% of folks who have a joint replacement have pain 3 to 5 years following the surgery. And finally, there's a risk of metal and material fragmentation. These are wear particles that can reach toxic levels in the blood. So what's the alternative? Well, the promise of regenerative medicine is that we can avoid surgery by using the body's ability to heal itself. We're using only needles through the skin, so it's minimally invasive. And what that means is there's minimal or no post-procedure recovery. Sure, you're going to be sore, but the body heals itself through inflammation, and that wears off rather quickly. The bottom line is that the promise of regenerative medicine is that we are going to preserve your native tissue. And once again, that's huge, because you have to understand that the human body's design has been refined over thousands of years. And that I would suggest to you that anytime we change that design, even slightly, whatever we get in return for that change, there's a cost to be paid for it as well. That brings us to orthobiologics, another one of those terms from the beginning of this lecture. This term comes from using a patient's biological tissue, their repair tissues, to treat orthopedic conditions. So orthobiologics, that's what we refer to the substances that we inject. We refer to them as orthobiologics. These are autologous, that's a fancy word for self, repair tissues. They are the repair cells of your body. We harvest them, we concentrate them, and we inject them very precisely. They come in basically two flavors. One is a small cell in the blood called a platelet. And when we concentrate the platelets down, the preparation is called platelet-rich plasma. In the Regenerative world, we call it super concentrated platelets, but in general, it's known as platelet-rich plasma. And then we also use adult stem cells. And in the Regenerative world, we find these in your bone marrow. So we aspirate your bone marrow. It's called bone marrow aspirate, BMA, or bone marrow aspirate concentrate, BMAC. Let's take a look now at the balancing act inside any joint in the body. The cartilage and bone of your body, you may be aware or may not, is constantly being remodeled. In other words, it's broken down and then it's laid down again, so that, you know, if you wait long enough, you have an entirely new skeletal system. But there's a balance in a healthy joint between the forces that degrade a joint and the forces that repair a joint. The forces that degrade a joint are catabolic forces. Now, that's a fancy word for breakdown. And in an arthritic knee, there are enzymes that are actually digesting the cartilage of that joint. Then there are pro-inflammatory factors. And this is bad inflammation. This is chronic inflammation. And chronic inflammation actually encourages the enzymes that digest cartilage. So it's a negative feedback loop that can really destroy a joint. As opposed to that, we have repair forces, which are called anabolic. Anabolic means to build up as opposed to break down. And basically what you're looking at here are various forms of growth hormone, which, you know, circulate throughout the body. And then you have anti-catabolic forces, and these are forces that inhibit the enzymes that are digesting cartilage and that also bind to pro-inflammatory mediators and remove them. So let's say you walk into my office or another Regenerative affiliate and you've sprained your knee. You've gone on a long hike and you tripped over a rock coming down out of the trail at the very end of the hike, and man, the knee is really sore and painful. We get an MRI, and what we find is you've sprained your MCL, which is your medial collateral ligament. Now, you haven't torn it, but you've sprained it. And this is notoriously a very slow injury to heal. So somebody like me would recommend, well, why don't we draw some of your blood and inject platelets very precisely into this ligament and speed up and help it to repair. So what happens when we do that? When we inject PRP, we get a whole host of anti-catabolic forces, alpha-2 macroglobulin, angiotensin receptor antagonist protein, TGF-beta. We get TIMP, which is tissue inhibitor of metalloproteinases. These are substances that really inhibit the enzymes that are digesting cartilage being spurred on by inflammation. And with PRP, with platelets, we get at least one very powerful growth factor called platelet-derived growth factor. And that's an anabolic, that's a growth factor. It will make things grow and repair. Let's imagine now a different scenario. Say you've not only sprained the medial collateral ligament, but you've also torn, let's say, a meniscus. And that tear is causing you a lot of pain. Well, in that case, we're going to recommend stem cells, which we get from your bone marrow. So we're going to inject you with bone marrow aspirate concentrate that we get from your hip bones. And with stem cells, we get a whole host of growth factors, VEGF, FGF, IGF, CXCL. The net result of injecting these orthobiologics into the knee is that we're going to tip the balance towards the factors that repair a joint so that we can outweigh the factors that are degrading your joint. That's really the gist of what we're trying to do. So what is this field of medicine that's attempting to do this? It goes by the name of interventional orthopedics. The core tenets of this new medical specialty are injectates, orthobiologics, as we just discussed, that can facilitate healing of bone, tendon, ligament, muscle, or cartilage. Very precise placement of those injectates into damaged structures using imaging guidance. And this is the skill level. This is where the skill comes in. There's a steep learning curve for being able to do this and hit these damaged structures very, very precisely. And finally, the development of new tools to facilitate percutaneous tissue manipulation. Percutaneous, fancy word for across the skin. So when we use a needle, we are putting it across the skin to reach tissues in a joint or beneath the skin anywhere that are damaged. So here's another look at interventional orthopedics. I showed you an algorithm earlier. Here's a very simple algorithm. Simple injections to surgery. Heretofore, there's been very little in between simple injections going to surgery. Simple injections, we're talking about just needles into a joint, beneath the joint capsule, into the interarticular space, it's called. 95% of US physicians who do simple injections into joints do them blind. And by blind, we mean they don't use any images. They don't use any guidance, imaging guidance. They just draw up some medicine, and with a needle, after they sterilize your skin, they stick the needle behind the kneecap, underneath the acromion, or down deep in your groin until they hit bone and they inject. Now, studies have shown, and reliably shown, that even the most skilled of these physicians, if they're not using guidance, they're missing their target 30 to 50% of the time. 4% of US physicians who do these injections use guidance. And of those, less than 1% are interventional orthopedics. But interventional orthopedics don't just do simple joint injections. These are all the structures that we inject in the hip. These are all the structures that we can inject in the knee. And these are all the structures that we inject and may need to inject to get your joint better in the shoulder. All of this in an effort to avoid surgery. So interventional orthopedics is the percutaneous injection of orthobiologics in an attempt to effect repair of damaged musculoskeletal tissues. What we're doing is we're accessing the body's innate ability to heal and repair. We're using only needles precisely placed using highly specific imaging. The analogy here is with interventional cardiology. The state of cardiology before the advent of the new field of medicine, now known as interventional cardiology, was that if you had a blockage in a coronary artery supplying the muscle of the heart, we had to do a procedure called a sternotomy. This is where we sawed through your breastplate and we opened up your chest and we went in and we cut out the blocked artery and we sewed in a new one that we harvested from another part of your body. But then along came interventional cardiology. And with interventional cardiology, we had the ability to make a small incision in your groin and thread a catheter up through your femoral artery into your heart, right up to the point of blockage in the coronary artery of interest. Inject a clot buster to break up the clot, and then deploy a stent that would keep the artery open. This is called IV stenting. Before IV stenting, sternotomies, when we used to have to saw through your breastplate, those procedures were doing nothing but increasing. After the invention of IV stenting, those sternotomies dropped to almost nothing. We rarely do that anymore. Similarly, with orthopedic surgeries, standard orthopedic surgeries, we think that there is a possibility with interventional orthopedics that those standard orthopedic surgeries will not have to be done anymore because we can solve the problem by injecting repair cells through the skin into damaged tissues. Why will interventional orthopedics eventually replace orthopedic surgery? Well, because number one, it's less invasive. Number two, quicker recovery. And number three, preservation of biomechanics, meaning we save the joint. We save the native tissues. We help them to repair themselves so that we don't have to replace them, cut them, sew them together. The final one here would be interventional orthopedics is a lot cheaper than surgery. And I think that fact alone is going to interest insurance companies, as it already is currently. So let's go back to our traditional treatment algorithm and see how it changes with the advent of interventional orthopedics. It's about the same up until the point where you get an MRI. You get an MRI and you see some damage, and a doctor like me looks at it and says, I think I can help you. Let's try an orthobiologic injection. We do that. We send you to rehab. We let time go by. And in best case scenario, we preserve the native tissue or the joint. And what we've done here is we've taken you out of this algorithm which marches you inexorably to joint replacement. Right here at the point of the MRI, take a left turn and take you out of it. We're about halfway through, and I thought we would just pause for a second and let those people who have time constraints leave if they need. But before I let you go, I wanted to make sure that you had our contact information. So how does all this work? Well, I've got some video to show you some actual procedure footage of what it is that we do. It's not great, but it's, it's something. This is a shoulder rotator cuff platelet injection. There's a small tear in the rotator cuff. The supraspinatus is right here. Here's your shoulder joint, this white line. This is the top of the shoulder joint, the ball at the end of the long bone of your upper arm. This is the deltoid muscle, which is the prominent muscle that covers everything. Underneath that, this is the supraspinatus tendon, part of your rotator cuff. You're going to see the needle come in here into this little rent that you see right here, and we're going to inject, and you're going to see that rent sort of fill up. So here we go. Here comes the needle. Now this is on a loop, so what you're seeing is you're seeing it over and over again. It's coming in, and then there, right there, that little flash, that's the platelets going in right here into the tear. Next is another shoulder injection. Again, here's the top of the shoulder. This is the labrum against which the shoulder articulates. And this little triangular shape here is the labrum. It's the lip of cartilage around the glenoid against which the shoulder joint articulates. And there's a capsule that you can't see here, but the needle's going to come down here right through the capsule into the joint. And when I inject, you're going to see the capsule light up. This is a bone marrow aspirate injection. So this is a stem cell procedure. There's the needle. You see it coming in. You can see the tip of it right here. And then we inject. You're going to see this capsule light up. Right there. So that tells me without a doubt that we've got the medicine where we need it to go. It's this type of visualization that is really key. This is a hip. Again, this sort of curved, highlighted white structure. That's the ball portion of the ball and socket hip joint. This is the lip of the socket. And this little triangular dark shape, again, is the labrum that deepens the socket. This is cartilage, and this labrum is damaged. And what you're going to see is a needle come down here. And what I'm doing is I'm jabbing, I'm tapping on this labrum, actually causing a little damage. And then I inject stem cells, bone marrow aspirate, BMA, concentrated, BMAC, over this, and you will see it go into the labrum and flow over it like a waterfall. Here we go. So that's the needle. And you see I'm actually doing a little bit of excoriation. I'm poking the labrum. And then when I inject, you're going to see this waterfall of stem cells flowing, there it is, flowing over the labrum and into the labrum right here. Again, the precision of injection is key to what we do. When we first started doing this, there was a question of how safe is this? We're taking stem cells from your bone marrow and we're injecting them into another part of the body. Isn't it possible that you could develop cancer doing that? Well, we didn't know. So we did a study back in 2016. 2,700 patients, 3,000 procedures. We followed patients for up to over 2 years afterwards to see if they had developed any cancers. What we found were 325 adverse events, and these were mostly just post-procedural discomfort and pain. What we also found were 7 tumors, 7 out of 2,700, for an incidence of 0.14%. And by the way, these tumors were not found in the tissues that we had injected with stem cells. So compare this incidence of 0.14% with the incidence of tumors in the general US population, 0.44%, more than 3 times that of the incidence from our study. If you narrowed it down to the patients who in the US population between the ages of 50 and 64, which more closely mimicked the people that we were injecting in this study, the incidence was 0.78, about 5 times more than the study population. We also found that there were 13 possibly related serious adverse events. When you do a study like this, you have to report every adverse event. And in none of these did we find a direct correlation with what we had done. But at any rate, the serious adverse event incidence was less than 1%, 0.55%. Compare that to the serious adverse events associated with total knee replacement of 6%. That's more than 10 times the rate of what we do in interventional orthopedics. Bottom line here is that the risk of orthobiologic injection is no greater than other intra-articular injections done in office by an orthopedic surgeon injecting steroids or hyaluronic acid. There's a small risk of infection, but if you observe aseptic technique, it's extremely safe. So what's the 30,000-foot view here? We're able to help patients with severe arthritis avoid a knee replacement. We're able to repair full thickness rotator cuff tears and help patients avoid shoulder surgery. And we're also able to heal full thickness ACL tears and help patients avoid ACL reconstruction. Starting with knee arthritis, what's the literature show? Well, we keep our own data, and that's why I'm a Regenerative affiliate, because of the people in this field who do this kind of work. Regenerative is the only affiliate that has any data whatsoever. So this is data where we were following, at the time, 5,852 knee procedures, of which 3,450 had knee arthritis, knee OA, as their primary diagnosis. All of these people underwent bone marrow procedures, in other words, stem cell procedures. And of these, the rate of people after 2 years after doing a stem cell procedure who were not happy with what we had done, who went on to have their joint replaced, was 12.7%. Another way to put that is that 87 out of every 100 people we treated were happy enough 2 years out after a stem cell procedure that they did not have a total joint replacement. This is a randomized clinical trial. This is level 1 evidence for the efficacy of bone marrow aspirate concentrate along with PRP injected into arthritic knees. This was a randomized controlled trial with 2-year follow-up. This was comparing a stem cell procedure to exercise. We let all the patients who were in the exercise group who didn't receive stem cells cross over to the stem cell arm after 3 months if they weren't happy with their progress. And all the patients crossed over at that time. What we found were significant improvements in the stem cell group compared to the exercise group at 3 months. And then thereafter, there were significant improvements in the stem cell group at all time points from baseline. But this is the study I really want to get to. This study came out this year. This is powerful level 1 evidence of the efficacy of stem cell procedures done in knees. It was done by Ernegau. Ernegau is one of the godfathers in this field. He's a French orthopedic surgeon. What he did was he took 60 patients who had arthritis in both knees of the same grade. And one knee he injected with stem cells. That was the IA group, intra-articular group. Hold on. I got ahead of myself. That's not the study I wanted to tell you about first. This is the study. Same author, took 140 patients. Again, patients with arthritis in both knees of the same grade. What he did was, in one knee, he injected stem cells. The other knee was surgically replaced. He followed them for between 10 and 20 years, an average 15-year follow-up. He started this in 2005. And here are the results. In the knee for which he did stem cell, bone marrow injection, 18%, 25 knees out of 140 went on to have their joint replaced. The average time to replacement was 10 years. So the people who got stem cells, who decided to go on to joint replacement, got at least 10 years of improvement before they went on to joint replacement. So the incidence of total joint replacement in this group was 1.19% per year. Now, in those who had their knee replaced, 21, almost the same amount, 15%, 21 had a second surgery to revise the original joint replacement because the joint replacement had failed. The incidence of revision, 1% per year, almost identical to the incidence in the bone marrow injection group. The conclusion was this study showed that subchondral bone marrow concentrate compared with total joint replacement had a sufficient effect on pain to avoid going on to joint replacement in the contralateral knee. This was quite revolutionary. It changed the way we practice stem cell procedures in the Regenexx world. The next study, which was published at the same time, January of this year, again by Ernigau, again with 15 years of follow-up. These are excellent studies, folks. Nobody has 15 years of follow-up. He took 60 patients, again, with arthritis of a similar grade in both knees. One knee he injected with bone marrow aspirate concentrate just into the joint, just easily into the joint, beneath the joint capsule. It's called an intra-articular. We call these the intra-articular group. The other, he drilled into the bone beneath the cartilage. That bone is called subchondral bone. This is called the intraosseous group. So one, he just injected stem cells into the joint capsule. The other, he drilled into the bone beneath the damaged cartilage areas in the knee and injected stem cells. And this is what he found. What he was trying to find was what procedure works better at postponing joint replacement. Well, in the intra-articular group, just in a simple injection beneath the capsule, the rate of total knee replacement was 5% a year. So at the end of 15 years, 70% of these knees had been replaced. Whereas when he drilled into the bone, the subchondral group, the IO group, the rate of total knee replacement was 1% a year. And after 15 years, only 20% of these knees had been replaced, 1 in 5. The conclusion was implantation of stem cells, MSCs, in the subchondral bone of an osteoarthritic knee is more effective to postpone total joint replacement than injection of the same intra-articular dose in the contralateral knee. Again, this changed the way we inject our patients. We inject the subchondral bone now based on this evidence, and we inject it with very large volumes of stem cells. Rotator cuff surgery. Is it necessary to have your rotator, full thickness rotator cuff teared? Well, the data seems to indicate that the natural history of cuff tears is improvement over time. There is no solid evidence surgical treatment benefited patients more than non-surgical treatment. And non-surgical treatment was found to be as effective as surgical treatment at 5-year follow-up. Here's a study that we did in the Regenexx sphere where we injected stem cells into rotator cuff tears. This is a randomized clinical trial. This is level 1 evidence. What we found, we followed patients for 2 years, 24 months after we did this. We compared them to a control group that just got exercises, cuff strengthening exercises. And here is the mean DASH score. This is the disability assessment in the shoulder and hand. Higher scores mean more disability. So you see in the treatment group, which is the dark line here, the scores drop over 2 years down to virtually 0. Shoulder pain, again, starting at about 4.5 to 5 out of 10 intensity pain, following the injection of stem cells over 2 years, drop down to virtually no pain whatsoever. This is a same study, one-time assessment by patients themselves. This is an assessment of their overall improvement as reported by patients. At 1 month, Very few people were reporting any improvement. At 3 months, more people reported improvement, 6 months, even more, 12 months, at 24 months, virtually everybody, except for 2 patients, outliers here, reported approaching 100% improvement. The average was 89% improvement. In addition, we got follow-up MRIs, and we blinded 3 radiologists so that they were looking at these films and they weren't told what was before and what was after, and they were to judge what was the best looking rotator cuff. Post-treatment MRI was the consensus pick in 14 out of 15 studies. There was a mean decrease of 26% in cuff tear size, and that was quite significant, particularly compared to the natural history of untreated cuff tears, which are expected to enlarge over time. Finally, ACL tears. This is a procedure that is really quite intricate to perform. And what we found is that we're able to help athletes stay away from having their ACL excised and replaced with a cadaveric ligament. This is how it's done. The patient lies on a table with what we call hook line position with their knee bent. We use a fluoroscope to take pictures. These are interprocedure pictures of dye flow into the various bands of the ACL, which is shown in cartoons here. This first study was a pilot study done in 2015. We took 10 patients, injected them with an average of 694 million cells per microliter into the ACL. And we waited 3 months and got follow-up MRIs, and all 10 showed decreased signal in the ACL, indicating repair of the ligament. This is the intra-procedure fluoroscopic view. This is an ACL that has just been injected with contrast dye. It goes at that steep angle here because the knee is bent at 90 degrees. The needle comes in from the front and we inject it. It's very difficult to hit this mark precisely. When you miss it, what happens is the dye flows out the back. This is a repeat study with more patients, 29 to be exact, done in 2018. 77% were objectively improved after more than 8 months. And this was based on MRI evidence of increased ligament density. This is a procedure that I did in a skier. Here's the ACL. It's really kind of amorphous and blown back here. 3 months later, this is not the greatest picture, but you can see it's much more defined and well down the road to healing. This is only 3 months post-procedure. Self-reported improvement was 72% at 23 months. There were significant decreases in pain and increases in function at all time points. Now, in this study, 17%, 5 ACLs out of 29 went on to have ACL repair surgery. Only one of these 5 retore their ACL. So 4 of them were treatment failures. And I throw that up there just to illustrate the fact that this is not miraculous treatment. This is a medical procedure. It has a success and a failure rate. But compare 17% failure rate to the re-tear rates on surgical repairs of ACLs, which are as high as 29%. Here are some more before and after. Again, blown ACL, 4 or 5 months later, very nicely defined ACL, much darker. This is a graph of the gray scale, a lot of gray in this ACL, very little gray according to the graph in this scale. And this, again, before, very blown, very amorphous ACL, post-procedure, very defined, very dark. One final thought I want to leave you all with. Orthobiologic injection is not a terminal procedure. What do we mean by that? A terminal procedure is a total joint replacement. That means that you've had the end treatment for your problem. There's nothing else to do from here except perhaps revise the total joint. In other words, yank out the replacement that we put in and put in another replacement. So that's a terminal procedure. Well, orthobiologic injection is not a terminal procedure. It's not a box that you enter and cannot exit from. Once you have a regenerative orthobiologic injection, you can go on to surgery. You can go to rehab. You can go to total joint replacement. One of the things about regenerative orthopedic injection is that we do not limit your options. There's no guarantee of success with anything we do in medicine. But one of the things I love to guarantee my patients is that I won't make them worse. And I can do that pretty confidently because I'm just injecting their own tissues through the skin into a structure. When it works, everybody's happy. When it doesn't work, there are other treatments waiting for you. So, take home, interventional orthopedics is a new field of medicine. We're using only needles through the skin. We're injecting orthobiologics, which are the self-repair cells of the human body. We are preserving native tissue, and that's probably one of the biggest take-homes, because I can't overemphasize that. Your native tissues are always, always, always preferable to any surgical repair or replacement. What we do is very safe. It is not a terminal treatment. And what we're doing has the potential to alter the traditional practice of orthopedics as we know it. I want to thank you very much for your time. This is a very brief, abbreviated bio for anyone who's interested. And now I will take some questions if I can figure out exactly how to do that. I have Margaret has raised her hand. So let me see if I can get to Margaret and allow Margaret to talk. Let's see, where are you, Margaret? I can't find you. Bear with me, I'm working on it. There you are. Didn't I just pass you? There you are. All right, Margaret, you're unmuted. You're muted, Margaret. You have to unmute yourself if you want to ask a question.
Can you hear me?
Yes, I can.
Okay, fabulous. First of all, thank you for that really great presentation you just gave. I love all the science you put there. I'm going to read each and every one of those studies you posted, and
Good.
terrifically impressed with this whole thing. And I'm very excited about it. I have two questions. One, I texted to you. I don't know if you got it. Did you?
You know, Margaret, you're going to have to bear with me here.
Okay.
I just, this is the first time I've ever run one of these, and if I can just, I'm going to stop. I'm going to hold on a second. Okay. You may have, and yes, I see that there are two chats here. Let's see if I can see yours, Margaret. Okay. I don't, you texted me. I don't see it here. I see something from Jill, something from Cheryl.
Okay. Well, I can repeat it.
Go ahead.
Okay. I, was first drawn into this procedure by reading the literature you had in your office, and they have graph charts, describing the efficacy of the procedures. However, I'm all about statistics. I've taken numerous statistics courses, and a major flaw, which I'm sure you're aware of with regard to their statistical analysis of the situation, is they do not reveal what percentage of their patient population responded to their questionnaire. So I don't know whether their statistics are based on 10% of the treated population, in which case, frankly, they're worthless, or 90%, in which case they're resoundingly valid. I contacted them, their representative, and asked them the question. I was met with a thunderous silence. Do you know the answer to that question?
Right. Well, the data, the registry data that we have, suffers from that bias for sure. I can't quote you what the figures are, but we have lots of patients who are just leading busy lives who don't answer the questionnaires that they are sent, that don't bother with it, get annoyed with having to do it, month after month, and stop doing it. So yes, the data that we have in our registry is what it is. But the studies I was quoting you,
that's the problem.
Well, the studies that I was quoting you, with the exception of the last ACL,
Yeah.
29 patients. That was a registry study.
No,
But
those studies are fabulous. I'm not questioning those. I'm just
okay.
questioning what Regenix put in their literature, because they, that's a pivotally important issue.
Yes, I couldn't agree more.
Yeah, so maybe you could get that out of them, being one of their participating doctors, because they just ignored me. So if you could do that, I would really appreciate that. That's my first question. My second question is, when do you decide to treat a patient with plasma therapy, and when do you decide stem cell is more appropriate?
We use plasma for lesser degrees of arthritis. We use plasma for simple sprains and strains and small tears in tendons and ligaments. If you have a big tear, if you have more advanced arthritis, we usually up our ante to the stem cells, the bone marrow aspirate. But you have to understand, when we use bone marrow, we're also using your platelets. We always do that. We mix them together because the platelets feed the stem cells. So when you have a stem cell procedure, you're also getting platelets. When you're getting a platelet procedure, you're not getting stem cells.
Okay.
Yeah.
All right. Thank you so much for these answers.
Looks like I have another question here. I have one from Brenda. Hello, Dr. Sutherland. I apologize. Just getting on your webinar and I missed the main content. Is it possible to get the whole webinar recording sent to me? It's being recorded and you can follow, you can get watch it again at your leisure. I believe you'll get a follow-up email about that, Brenda. So that answers that. What about osteoporosis? This is from Wendy. Osteoporosis is a totally different issue. Osteoporosis, for example, is not painful until your bones get so thin. And osteoporosis, by the way, not throw around medical. Osteoporosis is lowered bone density. In other words, the hardness of the bones is decreased. Osteoporosis is not at all painful until osteoporosis gets so bad that your bones begin to crumble, and then it's extremely painful. This is not a treatment for osteoporosis. Once your bones begin to crumble, injecting them with stem cells is a real Band-Aid. The whole idea of osteoporosis is to avoid getting to that point. And there's, lots of better treatment for osteoporosis than what we do. Other questions? Let's see. Done. Anybody? Questions? Raised hands. Let's see. Participants. I don't see any raised. Do we have raised hands? No, we don't see any. Well, if there are no further questions, I thank you all for your time. I really appreciate you showing up for this and spending some time with me tonight. Okie doke. Take care, everybody. Have a good night.